Hi, I'm Dr. Sarah Wasserbauer, and I'm here to talk to you today about the principles of hair transplantation. And I wanted to first say that it's a total honor to be asked by the World Trichology Society to be presenting this data. And I really look forward to any questions that anyone has and a conversation going forward. This shouldn't be just an end of the conversation, this should be the beginning. Let me share my screen with you here, and we'll get my PowerPoint going up. All right, here we go. All right, so this is all about the principles of hair transplantation. So if you've never done hair transplantation before, if you're just somebody who likes to diagnose, this should still be something of interest to you. And if you enjoy staring at hair, kind of like I do through a microscope, this should be a little bit more exciting than that. All right, here we go, as long as I can get my next one to go. All right. So what are the principles of hair transplantation? Well, if you're somebody who does hair transplant, then you understand that the first thing you need to learn is that genetics plus hormones equals hair loss. And there's a corollary to this, especially when you're transplanting hair, that more hair, giving a patient back, some of the hair on the front of the head equals happier patient. Now, none of us are going to be increasing the overall numbers of hairs on a person's head. It's what you're born with. We haven't figured out quite how to do that yet. One of these days, we'll figure out how to actually clone individual hairs and multiply the follicles. But for right now, what a hair transplant surgeon is just doing is multiplying or adding more to the front. We're not multiplying any tissue. We're just relocating some of the tissue. The second thing you should know, and this is just a quick overview, is that male and female hair loss is vastly different. Might seem like a new thing to some people, but for a long time, we thought that they were the exact same thing, and they are very different. Men generally lose individual follicles, have less overall trees in their forest, and for women, the trees shrink. So there's less wood. Now, in both cases, there's going to be less wood, but that's the initial difference between the two. The third thing I want you to know is the hair in the back of your head is genetically different than the ones at the top and in the front. You got to learn what the safe donor zone and what the donor or recipient dominance is. And I'll talk about this a little bit later. The fourth thing, help patients to plan to only transplant permanent hair in order to have a permanent practice or just have more permanent advice. So for those people who are looking outside of this permanent donor zone, they're going to end up transplanting hair that's just temporary, that's still DHT sensitive. And if you do that, you're going to end up with patients who have much more hair loss in the future and that you only have temporary hair transplants. So only refer to doctors if you're going to be referring to the doctor. If you're not going to be doing the transplant yourself, only refer to doctors who actually do only transplant permanent hair. And help your patients to understand that hair loss is by its very nature relentlessly progressive. They should add this to that list of death, taxes, and if you've got it, hair loss. It just progresses and progresses. There's nothing you can do at this point to stop it. We can slow it down, but we can't 100% stop it yet. Although I have some hope that in the future we will be able to. The fifth thing is that the sixth thing is that there's basically two ways to get hair from the back of the head to the front of the head. And like I said, this is all a hair surgeon really does, is to relocate hair from one location where we know it's perfect by its location and its genetics of that location to an area where it's been on its way out. And these two types of hair are called follicular unit extraction and follicular unit transplantation, or FUE and FUT. FUT is kind of the linear excision. Both can be absolutely beautiful surgeries with perfect scars, but both of them do have scars, and there's a lot of misinformation about that on the internet. Plus, surgery is only half of the treatment picture. When you do medical treatment in addition to surgery, it will always give you optimal results. So even though there's a million things that you can do medically speaking, people will sometimes only think, oh, surgery, and then I fixed it and it's done. Of course, surgery doesn't 100% fix it. And you always need to talk about the adjunctive therapies because that will always give more hair to your patient than surgery would alone or than medicine would alone. Sometimes you want to add surgery so that you get a complete picture and kind of holistically treat your patients. The eighth thing I want you to know is that there's basically 4 proven medical treatments for androgenetic alopecia, that's pattern hair loss, whether it's male or female. And if the scalp or the hair loss pattern looks a little odd, help your patients to avoid transplant, because usually it's not really a transplant suitable patient. The last thing is take pride in your profession. Advocate for conservative, natural hairlines that are permanent, that are not going to make your patients look odd as they age. A lot of hair transplant is done in younger individuals who are feeling particularly desperate at that time, and they want something that they remember. And if they're doing it in their 20s, what they remember is an 18-year-old kid, and that doesn't look good when you're 50. And the last thing, this is kind of an odd little take home because I happen to really enjoy writing test questions. Take your certifying exams. World Trichology, become certified to be the American Board of Hair Restoration Surgeons if you're a surgeon. But take those certifying exams to prove that you really are interested in hair and that you want to do something that's real and reliable and prove your professional worth. So here's the first principle: genetics plus hormones equals hair loss. It's just the way it is. What people usually come to me saying is, I'm this, I want to be this guy, but look at this guy. So first of all, this is a linear hairline. This never occurs in real life. Second of all, this is all kind of sprouting up in different directions. This is too low on his forehead for a normal aging guy. And you can see that there's a little black arrow behind here because I found this on the internet for an advertisement for a guy who's doing a hair transplant. Do you want to look like this guy? Well, this guy looks completely abnormal. Sorry about that. So this guy looks completely abnormal, and then yet they're selling this as a realistic possibility. It's not a realistic possibility. That's why every single red arrow, I'm like, don't think of this as what you want. So what you want to do is bring it to the what you want to do is bring it back to what a normal person would look like that's age appropriate. So your hairline is going to naturally recede. You're going to have a little bit of temple recession here, and you want to incorporate that into the final design of whatever this hair transplant is going to be. And from about here back, let me see if I can move my thing here. From about here back in this individual, you could probably save this hair with something like finasteride. Long-term finasteride therapy, you got to think of these things as like maintenance instead of just a one-time save all the hair, stop the hair loss. You got to think of this as like, oh, okay, it's like exercise. Got to do a little bit every day, or, you know, on an intermittent basis instead of one big thing all at once, because that's the way that it actually works the best. So hair loss patients are particularly emotionally vulnerable, and they make these decisions based on completely incomplete information. Completely incomplete information. They go on Google, and Dr. Google is usually trying to sell them something. So they get all this information that is not necessarily what they need for their particular case. So plan your consults to be as factual as possible. You want to be the ethical, in my standard, ethical hair surgeon, the ethical trichologist, the ethical person who's giving them advice, not just trying to sell them something or give them something that you do. There's another corollary to this. When you have a hammer and all you've got is a hammer, every problem ends up looking like a nail. So if all you do is mesotherapy, then mesotherapy is going to be the answer for everybody. Be the ethical person in the room. Ensure the integrity of our profession and the longevity of your practice in particular. There's a ton of snake oil salesmen out there, and everyone knows it. This has been going on since Egyptian times. Some of the first things ever translated were hair remedies. So be that ethical person who's really grounded in science. And if you weren't that person, then you probably wouldn't be here today. So I'm probably preaching to the choir. So let's talk about female hair loss being vastly different than male hair loss. Let me move this here. So male and female hair loss is vastly different. This is a chart showing the different degrees of female hair loss. And what happens usually in women is that they get overall thinning in this area here. So overall thinning means that those individual trees are getting more like saplings than oak trees. And in most men, that happens initially, but then men lose it. That's not what happens. Women maintain this hairline and then lose behind it. And you can see this miniaturization under your trichoscope. You can look under magnification and you can see this. And you can see that even though this is not the most complete and wonderful way to grade a woman's hair loss, this one's actually the Sabin scale. You can see that it just progresses slowly over time. Whereas in a guy, you'd end up with the temples and the crown going bald, and then usually the whole top of it kind of all connecting. So make sure that you learn the difference. Now, here's the other thing about it is male pattern androgenetic alopecia, male pattern hair loss, can actually happen in a female. I've seen it a lot of times. Lots of people have. So you can have loss here and loss here in a female, and you can actually have female pattern hair loss in a guy. So when you have this kind of hair loss where you've got a guy that has a diffuse loss all through this frontal area, female pattern hair loss in a guy. Now you might choose to treat these differently based on the physiology of that individual. And it's always fun to get people who are either transitioning or they're on hormonal therapy for something else, because that really makes you think, okay, is this male pattern or female? Because then you're thinking of what the etiology is, and then you're thinking how you can best treat it. But you can have, this is the take-home message, you can have female pattern hair loss in a guy and still treat it like male pattern hair loss, normal male androgenetic alopecia, okay? Because their pattern is just different, but the underlying cause of their hair loss is still probably dihydrotestosterone and genetically susceptible hair. It just happens that the genetically susceptible hair is in a female pattern. Got it? All right. We'll move on to the next one. You can ask me questions about that one later. All right, let me try and move this again. Now, here's another thing. The hair in the back of your head is genetically different than it is on the front and the top. This is taken from one of the classic textbooks that most hair surgeons use, showing the safe donor area. That's this right here, okay? So the safe donor area, insofar as we have been able to tell over time when looking at guy after guy after guy, is just in this rind, this horseshoe. And even that safe donor area slowly goes over time. You've got the measurements right here, about 4 centimeters, 40 millimeters from the top when the border is first seen. You lose this temporal point here, okay? So this will go back. That's why you try to avoid taking anything in front of the ear if you're planning on having a permanent hair transplantation. And you also have to look out for anterograde versus retrograde alopecia. So this is anterograde when you're losing the hair in the front. And I'm talking mostly about male pattern hair loss here, but retrograde is going to be up the back. So if you're looking for where you can actually get hair that's going to stick around, and you're a hair transplant surgeon, you're going to want to help your patient to plan a transplant that is only taking from the safe donor area, from the permanent zone, and educate them that you can go higher and lower to get more hair, but sheer hair numbers is not the whole story. You really want to make sure that you are being cautious, maybe feathering it into the areas that have a high risk of thinning, but not getting the majority of your grafts from these areas, because then a hair surgeon is going to be giving you a temporary hair transplant. So caution your patients or somebody that you're seeing in a consultation. When they ask about these questions, tell them exactly why it is not advisable to take every hair that's possibly available to you. You need to make sure that it's only from the area that we know that with time will stick around, because you're not going to be 20 or 30 or even 50 or 60 forever. If you're going to be living into your 80s and you want to look normal, you have to take these things into account, okay? Now, linear excision surgery, I'm probably going to talk about this next. Linear excision surgery usually only goes from the safe donor area. If you're feathering in an FUE surgery, it will often feather into the upper and lower areas where there is a high risk of thinning. And there's ways to tell whether or not those hairs are more likely to be permanent, but you don't have any concrete way of doing that. So you got to be cautious. All right, so here we go. Basically, there's 2 ways to get hair from the back of the head to move to the front of the head. Linear excision, which is, well, one at a time, which is FUE, and linear excision, which is often on the internet referred to as FUT. Now, FUT technically refers to follicular unit transplantation, which all reputable hair surgeons now perform, that's moving one follicle grouping, one follicular unit at a time to the front of the head. So FUT kind of is a misnomer, but people often use that to refer to linear excision. We're trying to turn that boat around right now, but just for the purposes of this discussion, FUE and FUT are the two ways that we can use to move hair. So with linear excision surgery, I like to use a birthday cake analogy, okay? If you got a birthday cake with all kinds of candles in it, if you are doing linear excision surgery, you're taking a big swath of cake through the middle, you're taking that cake out with some candles, and you're separating each candle, carving out a little bit of cake around it, and that's your graft. And then with the remaining cake, you're pushing the two sides together so that you have a little seam in the middle. That's your scar. With FUE, same cake. But what you're doing is you're taking a little inner tube to a roll of toilet paper and you're centering it on a candle and you're going, and then you're going back and with forceps, you're taking out that little core of cake with a candle in it. And that's what's being transplanted to the front. And then if you look back at that cake, now you have cake still with some candles left, okay? But with little holes that get filled in by icing. In the first example, that seam in the icing is the only evidence that you've been there. The candles on either side still have the same density. In the second example, the FUE example, there's less density on either side of in the whole donor region. So overall, it looks less dense. It looks a little more sparse, okay? But the scar itself is diffusely camouflaged because it looks more like a shotgun blast than a line. And remember, your occipital cortex, as it's developing in just, infancy, is trained to see lines and edges and corners. So you're always going to be able to pick up a line visually than you would ever something that's a more diffuse, multi-dotted appearance, okay? Both of them involve surgery. Saying one is non-surgical is completely bupkis. Both of them are equally invasive. You're going to the same depth in the tissue. They both have pain. They both have scarring. The shapes of the scars are different, and you're cutting into the skin with both of them. There's a lot of misinformation out there about what exactly is going on with a FUE surgery, and most of this information is being provided by the companies that make the FUE machines in an effort to get more patients interested in their technology so they can sell it to doctors. But both must be performed by a physician. And legally, parts of the surgery can be delegated to, I live in California, they could be delegated to somebody called a nurse practitioner or a physician assistant, but not the whole surgery. And only when I already know how to do that whole surgery beginning to end, alpha to omega, all by myself. So doctors who just bring in an FUE team and who don't know how to do a hair surgery all by themselves would not be legally allowed to delegate this surgery to anybody else. And you have to be careful because laws change all around the world, and some laws exist in other parts of the world but are not enforced. So you got to be really careful that only a legally licensed practitioner is performing this surgery, because then you have a fallback, right? So only refer to doctors who are going to actually be doing this for you. And that's why you are all here. Now, I often use analogy of an amount of trees in your forest. My apologies. So there's a forest of trees on your head. And this is when I talk about the number of trees that you have versus the amount of wood. So if you get more trees on your head, yeah, you're going to look more dense. But if you do the math, the best way to get more density and more wood on your head, which is actually what correlates to the appearance, is to actually increase the diameter of each individual tree. So hair loss is by its very nature progressive. And I like to say this because denial ain't just a river in Egypt. Most people think that hair loss will have stopped. This is a very famous bald guy. And you can see that this hair is no longer around in this particular individual, but probably in this case, he thought, oh, my hair loss has slowed down. I'm probably pretty good. Well, that just doesn't happen. And so when you're planning a hair transplantation, you have to be able to either convince your patient of the utility of planning for future hair loss, or just show them a picture like this, where they can see that the hair loss did not stop, and now they have gaps. See between here. Now, this is an old plug. version of surgery, so it's not the best to look at, but you can see that there's a gap between where he transplanted the hair and where the hair was before. Same thing here. He had hair, he had lost hair at the frontal area, but he had hair behind. So they just filled it in the frontal area. Now he lost hair behind, and he also has this little tuft at the back where he had lost hair there before, and now it's gapped around it. So there's a moat of hair around this little tuft at the center. Now there's some cases where the person comes in, they only have the tuft at the center and nothing else on their head, and then they look like, oh, Ernie from Sesame Street, or like a magic hair yarmulke in the middle of their head. Those are not the ways that you want to have something happen for your patient. So make sure that they understand that things change. Now, here's an open-ended question. Name one good thing and one unfortunate thing about this transplant. I would say that the good thing is actually that this guy's hair is very curly. And because of that, it has a lot of volume and it can kind of camouflage a little bit better. And the second, the unfortunate thing about this transplant is that it was old plugs. Now, you might be able to recycle some of those old plugs if you've got a hair surgeon who knows how to do the regenerative work, or pardon me, the reconstructive work. These can be reused all over the head, so they might not lose all of this hair. And it's curly. So modern techniques might be able to rescue this patient, and in fact did. But those are just things to watch for. And surgery is only half of the treatment picture. Remember, medical treatment plus surgery will always give you the optimal results. Think of medical treatment. If you got this patient, medicine's probably not going to, finasteride, minoxidil, it might help this hair, but it's probably not going to save it in the long term. Back here, though, it probably will. You'll probably be able to maintain all of this back here. And you'll probably slowly lose that up here. So you think Propecia and Rogaine for the back, for these areas, and you think hair transplant for the front, okay? Now they might still slowly lose this over time, especially if the hair shaft diameter is less than 40 microns. You might be able to save it for a little while, but it'll probably eventually go on a male. If it's greater than 40 microns, you might be able to regenerate that and keep it. That's kind of the mantra. The 4 proven treatments for androgenetic alopecia, the ones that we have actual science for: photobiomodulation. I mentioned this first because most people don't know the history of photobiomodulation or the fact that it actually does work. The reason is we're all victims currently of devices that don't work. Unfortunately, they're just ineffective. And that's because the hair is getting in the way of the light. Eventually, we will have devices that actually get the light to the scalp in every case, whether there's hair there or not, and then photobiomodulation will really take off. Remember that low-level light therapy has to be within a certain wavelength. The one that's most studied is 668 to 684 nanometers, but it might be 830 nanometers. And you'd probably have to do it between 14 and 20 minutes 3 times a week or every other day. That's what the initial data is telling us. There's shampoos that help. Zinc pyrithione shampoo, which is Head and Shoulders in the United States. Selenium shampoo, which might be known as Selsun Blue on your, grocery store shelf. 1 or 2% ketoconazole, which over the counter is sold as Nizoral. There's coal tar shampoo, which is like here in the United States, it's called Neutrogena Tea Gel. It's the brown one that's on the shelf. All of those, you got to think of them like a medicine, not a shampoo. And you want to leave them on your head for a good 5 minutes, which is a very long shower. Like I said, I'm in Northern California, which is particularly drought prone, and nobody ever spends 5 minutes in the shower. So I tell people to put it on dry, go get a cup of coffee or check an email, and then come back later and rinse it out. And that's how it's most effective. 5-alpha reductase blockade. Now there's 2 drugs in this category of medications. There's finasteride and dutasteride, and that's it. There's all kinds of ways of dosing these medications so that you avoid the unwanted sexual side effects, but nobody talks about that on the internet because it's way more clickable for the bad news to spread to hear that there's a good way to use these medications and keep your hair. So a good medical practitioner will be able to know 5 milligrams once a week. You could do 1 milligram a day, sometimes half a milligram a day. And there's some efficacy to topical finasteride, but it doesn't always work, probably because of the differentiating absorption due to the sebaceous glands on the top of your head. And dutasteride, you can even consider taking it once per week or in conjunction with finasteride. There's some data there. Minoxidil, whether you do it oral or topically it's known as Rogaine. works very well. And all of these treatments seem to potentiate the action of a surgery, and the surgery seems to help the medications to work well. So do all that you can all at once, and you'll get the best results for your patients in that way. If the scalp or hair loss pattern looks odd in any way, you should avoid transplant, okay? So this would be frontal fibrosing alopecia. You see this right here, very slightly, you can see the line where they have sun damage here, but nothing beyond here. That's kind of a clue. And the hair looks smooth, and this doesn't look like a normal female pattern hair loss. This is somebody with either a burn scar or alopecia areata. There might be a little bit of inflammation in the middle there. And then this would be somebody who you would also worry about, maybe central centrifugal cicatricial alopecia, although this is not an African-American female. This actually happens to be a chemical burn scar from somebody who was getting their hair permed or colored. So, but if the pattern looks odd, usually you want to avoid transplant or just do a little test patch, because you need a diagnosis before you just run straight in. One of the other principles that I wanted to impart was to represent the hair industry well. We've been the kind of punching bag for a long time because we haven't done the greatest job of transplanting or correcting hair in a natural way that makes it look good or that's effective. So you want something that's conservative, that's natural, and as permanent as you can get it. So even though this isn't a question for later, I wanted to ask the audience, do you think this is an original or a transplanted hairline? So click below to find out. This is actually that was a transplanted hairline. This is before they are transplanted. You can see that there's no hair in this area. And you should take pride in that and find people to refer to. If you're going to be transplanting a hairline, look for, making your work as natural as you possibly can. That raises the whole industry. And avoid those people who make straight hairlines or hairlines too low. That just won't work. So to review, remember, genetics plus hormones equals hair loss, and that male and female hair loss is vastly different. The hair in the back of your head is genetically different than the top of your head. Help patients to only transplant that permanent hair in the back of their head, and help them to realize that hair loss is not like a one-stop shop. If you do a hair transplantation, it's not going to cure your hair loss. It might help your hair loss temporarily for a very short time, but you have to incorporate medical therapy in addition to everything else. It's like maintenance, a little bit every day, because it's relentlessly progressive. Now you can choose either a linear surgery or an FUE surgery. Both of them can be beautiful results. Don't listen to the internet that says, oh, just an FUE works, just a linear works. Sometimes in order to get the best results, you have to do both of them together, which is called a hybrid surgery. But you need to have a surgeon who's able to do them both so that you avoid the hammer and nail problem, where if all you have is a hammer and all you can do is FUE, then every problem looks like an FUE problem. And like I said, surgery is only half the treatment picture. Make sure that you incorporate everything that works for that patient into that patient's treatment regimen. I went over the 4 basic proven medical treatments for androgenetic alopecia, and I warned against just transplanting or just treating if the pattern looks odd. Take pride in what you do. This is a wonderful profession. I love dealing with hair patients. They are the most grateful. Take them seriously. Don't minimize their concerns. Advocate for conservative, natural, permanent hairlines and as much hair improvement as you can get. And then lastly, take your certifying exams. If there's a certifying exam that you can get, absolutely do that. Raise the bar in our industry. If you're a surgeon, take the American Board of Hair Restoration Surgery exam. And that's it. We're here to help you. Love all current hair surgeons.